Welcome to today's EACVI webinar on the new 2017 recommendation on application of contrast echo in clinical practice by the EACVI. I'm your host for this webinar. My name is Professor Roxy Senior from the Royal Brompton Hospital and Imperial College London. I have with me two very experienced people in the field of contrast echo. On my right, Bharati Shivalkar from Antwerp, Belgium, and on my left, Nicola Gaibazzi from Parma, Italy. The aim of this webinar is to give you an informed understanding of the 2017 recommendation of the use of contrast echo in clinical practice and the basis of the recommendation. The webinar will be divided into two broad topics. The first topic will be application of contrast echo for assessing cardiac structure and function, presented by Professor Shivalkar. And the second topic is the incremental value of myocardial perfusion during stress echo or suspected acute coronary syndrome, to be presented by Dr. Nicola Gaibazzi. During both these presentations, the basis of contrast echocardiography, pathophysiology, and the protocols will be discussed, and these will be discussed with the illustrative case examples as shown in clinical practice. At the end of the 60-minute live webinar, you will have knowledge of the basics of contrast echo, use of it to assess structure and function, how regional wall motion abnormalities and perfusions are assessed, the incremental value of perfusion over wall motion, both in the detection of coronary artery disease and the prediction of outcome, and finally, how contrast echo helps guide patient management in various clinical scenarios. The session will be highly interactive. We strongly advise and encourage the viewers to submit questions online throughout the webinar. We will endeavor to answer as many as possible within the constraint of time. For optimum participation, we will also encourage you to join in the online MCQ session, where you will need to answer questions pertaining to the webinar that you attended today. Anything you need to know, just ask, and we will provide tips and tricks for your daily clinical practice. Finally, I would like to add that the webinar is made possible through an unrestricted educational grant provided by Bracco, Milan, Italy. Now, over to you, Bharati, for the first presentation.
Well, thank you, Roxy, for this introduction, and thank you, the organizers, for this invitation to present this topic here. I have no relevant disclosures. So the objectives of the talk today are to look at the proven safety and efficacy for the use of contrast in daily practice, to look at the recommendations for the imaging with contrast, to identify the clinical applications, and also the sound laboratory practices for the use of contrast. It will be interesting to look at how experienced our audience are in the use of contrast. So this is my question to you, and I would like you to participate in that, dear audience. How often you use contrast in your lab? So either you don't use it because harmonic imaging is good enough for you, or because there's no reimbursement and out-of-pocket payment is not possible, or because you don't have any formal training. Or the fourth option is that you do use it regularly in stress and or rest situations. So please go ahead and answer.
Great. So Bharati, what about in your lab? So let's talk about stress echo. How much contrast do you use in your stress echo scenario?
Well, the threshold to use contrast is very low. So, I mean, we have several colleagues doing that, but I use this in almost every patient, because even if the image quality is adequate, I think you have added benefit of using contrast. So, you know, I use this a lot.
And what about you, Nicola?
Yes, it's the same for stress echo in particular, but also for rest in some cases, for cardio-oncologic cases or ICD implantation questions about the LVM. So this is very useful.
Right, so it's very interesting that you use quite a lot of contrast even in resting echo. So I think we have come up with some answers to your question, Bharati. So actually the 42% use contrast on a regular basis in rest and stress. So that's pretty impressive, I must say.
Yes.
That's wonderful.
So I think it's a good start. So let's move on.
Let's move on, indeed.
Selection bias.
So recently, the EACVI and the AAC produced a recommendation paper and the guidelines on the use of contrast. And despite the availability of contrast and the ease of the utilization of the contrast, both papers stress that point, that the use of contrast in daily practice is very low. In stress echo, the uptake is rather high, but it is shown that recently it was shown that in less than 7% of the transthoracic echo, contrast is used. Now, this could be because of perhaps limited knowledge in how the contrast should be used. It is a very safe technique and cost-effective. So I do hope that after this webinar, there will be more people interested in using that. So let's have a brief look at the physics of this technique. So we use microbubbles, which are actually smaller than red blood cells in size, but when injected in the circulation, they have the same rheology as blood cells. The microbubbles actually oscillate when exposed to ultrasound waves, and they have a very strong backscatter index compared to the red blood cells and biological tissues. They are nonlinear in their oscillation, and they generate very strong harmonic signals. And this is the property which is actually used in this imaging technique. So there are contrast-specific imaging modalities which different vendors use. So you have a couple of techniques I mentioned here. The pulse inversion technique, for example, where the second wave which is generated, pulse which is generated is inverted, and tissue tends to behave in a linear fashion during low mechanical index scanning, and the reflected waves simply cancel each other out, and there's no tissue signal. But because of the nonlinear behavior of the bubbles, you have a pure harmonic signal which is generated by the bubbles. The other technique is amplitude modulation, where the second wave, which is transmitted, is half the size, half the amplitude, and upon reflection from the linearly behaving tissue, it is amplified to twice the size. And when the second wave is subtracted from the first, again you have no tissue signal, whereas this is not the case with microbubbles, which are non-linear oscillators, and you have a pure harmonic signal.
So Bharati, let me stop you in your talk now. So between these two techniques, pulse inversion and power modulation, which would you think would be more optimal for LVO pacification?
It is definitely the power modulation which is better, because you have much nicer filling of the apex and less attenuation.
And also because in pulse inversion it utilizes purely harmonics, and harmonics are not great at the back of the heart, while power modulation actually utilizes also fundamental signals which are available at the back of the heart. Absolutely. And therefore there's less attenuation. Yeah.
Absolutely. So again, another word about coming to imaging, the mechanical index. So bubbles oscillate much more when you have a high mechanical index scanning, and so they simply burst and are destroyed. So for the scanning, for contrast, you either use intermediate to low mechanical index, so ideally 0.2 and lower. And the frame rate should also be at more than 25 hertz.
So Bharati, when you say low mechanical index, you mean less than 0.2, right?
Less than 0.2 indeed,
yeah. Okay.
Yes. Yeah. So to be able to see the structure, the function, as well as then you can also look at perfusion then. So here's a list of the available contrast agents in Europe. They're all second generation bubbles, and all of these are actually suitable for the assessment of LV structure, function, and perfusion. So these all pass the pulmonary circulation and are large enough, in fact, to generate strong signals which we can detect. Now, there's a whole load of data on the safety and efficacy of the bubbles. Today, just mentioned in these papers, different studies, you've got almost 4.8 million patients in an inpatient and outpatient setting in rest and stress studies, prospective and retrospective studies. And what they all show is that, in fact, this is a very safe technique, and the risk of significant reactions is less than 1 in 10,000. There is a proven impact on outcomes, and it is a cost-effective technique.
Now so Bharati is actually the safest technique, safest safety profile that contrast has compared to other imaging techniques which use gadolinium, radio contrast agents. Would you agree to that? That is much safer than the other techniques.
I'm an imaging specialist. I also work with CT, and you see a lot more allergic reactions with the contrast we use for CT than for echo. So there's no doubt about that. So the efficacy of contrast to improve the definition of the LV endocardial border allows us to assess lesion of wall motion very accurately. It also allows accurate quantification of LV volumes and the ejection fraction, and we are also able to assess structures which may not be so obvious with conventional scanning, such as thrombi, etc. And the recommendation for all of these is more than class 2A. And certainly when patient management becomes important, such as in stress echoes, for example, where accurate assessment is important, you have a class 1A recommendation. So there's reimbursement for this in several countries for this particular indication. In our lab, we use SonoView, and it's actually very straightforward to handle that, the product. So you have a small vial with about 25 milligrams of dry powder. You mix saline into it, which is also provided in the kit. You shake it vigorously for 20 seconds, and you have 4.5 milliliters of a milky contrast fluid, which is ready, in fact, to be injected. So either you can inject it as a bolus, or you can give a continuous infusion, for which the special pump, which is developed by Bracco, which is used, and it actually mixes and infuses at the same time. Now, important here to realize is that optimal contrast concentration is required for optimal images, and so you have to really talk to the person. You have to work together very well with the person who's actually administering the contrast. So this is an important issue, and you must understand that aspect very well. A good IV line is very important, so 20 gauge needle ideally. For SonoView, you would give 0.5 milliliters of contrast, after which bolus of saline is given, 5 milliliters ideally, about over 10 to 20 seconds. And then you should wait for about 20 seconds before you actually start the scanning. And then one should adjust indeed the mechanical index, the focus, and gain during that time to obtain optimal images. Now, this is an old cartoon which actually shows the journey of the contrast bubbles, passage through the lungs and into the myocardium, into the cavity and the myocardium very well. Now let's look at some examples. This is my first example. A 68-year-old female with signs and symptoms of heart failure. And it's important here, obviously, to not only assess the region of wall motion, but also the global function. And so in the non-enhanced images, there were several segments which were not detectable very well, but the contrast-enhanced images, very clearly you see all the regions, and you can also reliably quantify the volumes and also the ejection fraction. My second example is a 40-year-old man, a smoker, with chest pain and normal ECG, and I think you will agree with me that the 4-chamber view shows that we could use contrast here. Now, most machines have presets for contrast imaging, but fine-tuning may sometimes be necessary. So here at the mechanical index of 0.4, you have swirling of the contrast and destruction of the contrast in the apex, and by turning the mechanical index down, we have this very nice opacification of the apex, and we can assess the wall motion there very well. By turning down the mechanical index even further, the bubbles, you can see the bubbles entering the myocardium, and this setting is used ideally for perfusion studies with the flash replenishment technique, which my colleague, Dr. Gaibazi, will expand upon later. Now, interesting also to see here the difference.
Just before that, Bharati, if you're looking at your lower left image with MI of 0.2
right.
versus MI of 0.1, you will see that the LV opacification is much more uniform with 0.1 than with 0.2. You see some bubble destruction at the apex, but you don't see at all there.
That's right.
So this is one of the advantages of using low MI, isn't it? You get more uniform LV opacification, you give less contrast.
Less contrast, right.
And you can also look at perfusion.
Exactly, exactly. And the point that I wanted to make also was here the volumes which are calculated here. So the volume, the contrast opacified image is a lot higher, because with the contrast you can see actually the compacted myocardium, and you're excluding all the trabecals and the papillary muscles, etc. So the contrast gives higher volumes. Another case, 52-year-old female, multiple risk factors, chest pain, and if you look at the the B mode colorized image, you might think that the function is actually normal, but when you look at the contrast enhanced image, there's an extensive wall motion abnormality most pronounced in the mid-infralateral region. And so, without contrast, this is something that we would have clearly missed.
And actually the reason why you see in non-contrast a clearly moving myocardium, if you just go back the slide, if you play that again, and it's not that you're seeing the muscle, what you're seeing there is trabeculae.
Right.
And with contrast, you actually remove those trabeculation, you don't see that, and you see the compacted myocardium. And therefore it is it more accurately assesses compacted myocardium than the non-contrast images.
Absolutely. Absolutely, and which also gives the higher volumes, in fact. Right. Then application in stress echocardiography. This is a 65-year-old male, a diabetic, rather a large man with chest pain. ECG and troponins were negative. Now at our lab, we do, of course, the standard 2D imaging, but we also do 3D imaging on a regular base, multiplane as well as full volume. And so I'm going to show you a triplane 3D acquisition here. So there are several segments which are actually not visible. When we gave contrast, we could see actually that there was some degree, it seemed some degree of apical wall motion abnormality. Now at peak stress, even in the non-contrast image, that became a bit more obvious, but lo and behold, when you give contrast, you see this extensive area of dyskinetic apex, and the wall motion abnormality actually also extends into the anterior wall. And the patient obviously got a cath, and there was a tight proximal LAD lesion, just proximal to the bifurcation of the first diagonal branch, and he was stented.
In fact, this highlights the point that you just made, that even with a reasonably good echo window where you can see the endocardium, contrast still helps in stress
absolutely.
echo and bringing up it, more clearly the abnormalities.
But clearly, and the extent, which is also becomes very obvious.
Yes.
Now, this is an important paper here. So you see contrast echo, which is being compared to non-contrast enhanced echo, cine angiography, and MRI. And the accuracy of contrast enhanced images is clearly higher than non-contrast and angio, but is also higher than MRI. So this is for assessment of wall motion abnormalities, and also in the setting of stress echo. And this is in fact with intermediate degree of stenosis, where contrast enhanced images were very accurate in identifying problems when invasively measured FFR was used as a comparing standard. In this more recent study, the authors looked at several imaging techniques and also the inter-observer agreement for wall motion abnormalities. And you see here the 2D contrast-enhanced echoes were clearly superior. The agreement was much higher than the non-contrast images and very similar to that of MRI and cine angiography. Now, quantification accurate quantification of volumes and the ejection fraction. The indications for that are obviously where it is important for clinical management, and the indications are listed here. Before ICD implantations, in CRT, cardio-oncology patients, and also in valvular heart disease, where surgical decision is dependent on then accurate assessment of the ejection fraction. Now, an important point to remember here is that even though the ejection fraction may correspond in non-contrast, contrast, and perhaps another modality that you might be using, that the LV volumes do not agree in contrast versus non-contrast echoes for the reasons we've mentioned before. So here's an example. On the top you have end-diastolic and end-systolic images, and down here, again, the contrast enhanced, and you see clear delineation of the compacted myocardium, the reason why the volumes are much higher. This is an example just for illustration. A patient with oncology, gastric cancer, and she was undergoing chemotherapy. She had palpitations, chest pain, short of breath, and so the oncologist sent her to us, and he wanted to know what the ejection fraction was like. And she had some extrasystole, and so with the contrast, we could assess not just the regional function, but also the global function, and that was moderately depressed compared to the baseline ejection fraction of 52%. Another example here where a patient with an indication for ICD implantation, but there was some concern here regarding the presence of an apical thrombus, and so we used all our tips and tricks for ruling out apical thrombus with the conventional imaging, and we couldn't rule it out. But once a shot of contrast was given, it was immediately obvious that there was in fact no apical thrombus, and we could also quantify the ejection fraction very accurately. So when you compare contrast images, 2D contrast images, to other modalities, MRI, even cine angiography, and also cardiac CT, for wall motion abnormalities, volumes, and ejection fraction, 2D contrast is clearly superior to non-contrast. Now, another indication, as we talked about before, looking at structures which may not be so obvious in conventional, intracardiac structures which may not be so obvious in conventional scanning. So here's wall motion abnormality with thought to be an apical thrombus there, and it becomes absolutely obvious, clear, when you give contrast at low mechanical index. There's this black mass, avascular mass in the apex, which is the thrombus. You also see the wall motion abnormality very clearly, and you can simultaneously also see the perfusion abnormality, which is extensive. Next example is that of a myxoma, and it is partially vascularized, partially fibrotic structure, and partially vascularized. And the third one is a metastatic tumor, which is highly vascularized. And when you compare that to the heart muscle, you see that the replenishment of the bubbles is very similar in the tumor compared to that of the heart muscle. So we've got three examples: thrombus, myxoma, and metastatic tumor. And in this very interesting study from Sweden, it was shown that with conventional scanning, one misses almost 50% of the cases. The conventional echo is non-diagnostic in at least half of the cases. And when you give contrast, more than 90% of these become diagnostic.
In fact, I mean, what you're showing here is you're actually characterizing the mass in terms of perfusion and the mass itself, very similar to what MRI does. And therefore, this should be the technique of choice initially to do that.
Absolutely, because it's bedside, it's so simple and
much less cost.
Absolutely.
Yeah.
Absolutely. Okay. So another interesting example, actually, echo-free area adjacent to the apex, and it wasn't quite clear what it was, but after giving contrast, it was very obvious that in fact it was a pseudoaneurysm, and these arrows actually also show the neck of the aneurysm. Recently, this patient was sent to us for an echo by one of our EP colleagues, and this ECG is very typical for an apical hypertrophy. But our regular echo, in fact, didn't really show that, didn't really confirm the ECG findings. And so we gave contrast, and we also did multiplane imaging. And in the multiplane imaging, you can see very clearly here that the apical hypertrophy could be diagnosed. And so, you have to use everything, use contrast, use multiplane imaging, so that you can come to your diagnosis. You have all these things at your fingertips, so do use them. Time for troubleshooting. This is apical hypertrophy. Now the scanning here is at high mechanical index, and you see a lot of swirling of the bubbles because the bubbles are actually being destroyed here at this high mechanical index. So we've said, there's most echo machines have contrast presets, but you may need some fine-tuning for that. So here, even at a mechanical index of 0.4, there are bubbles being destroyed. So here you would manually turn the mechanical index down. Now, in this case here, so what we see is actually the apex is very well opacified, but you have down here a lot of black, which is attenuation. So in this case, there's a lot of contrast. So you would wait for a little while, up to 10, 20 seconds even, before you acquire the images, because then you have uniform distribution of the contrast. This case here, there's in fact too much contrast here. So you've got blooming of the apex, And so again, you would wait here a little longer before you do your scanning or reduce the dose of contrast given. And finally, in this case, which is a large ventricle and hypercontractile, the standard dose of contrast is not sufficient. So you see a lot of swirling around. And so in this case, you would have to increase your dose of contrast to get optimal opacification of the cavity. So the EACVI actually recommends training, recommends the requirements which are necessary for optimum use of contrast in your echo lab. So you should, in fact, learn how to perform it, how to do the contrast studies, how to interpret it, and you should also realize what the pitfalls and the adverse effects are. Adverse effects meaning the side effects, possible side effects. And for LVO, 25 supervised studies are sufficient. For stress echo, 50 supervised studies, and for perfusion, 100 supervised studies should be done. And for all of them, to maintain your competency, 50 per year. And obviously, the stress echoes, you should be able to confer with the angiography. And finally, the EACVI paper also provides you a checklist for contrast echo, and I suggest that you follow that checklist, which is really important. You should check for the indication, you should check for correct administration of the contrast, you should check for eventual side effects, if there were any that the patient might have had, and finally also document the indication and the amount of contrast used in your report. And finally, I would like to end my presentation here with my second MCQ, just to see if most of the audience are awake or not, have been listening to the talk or not. And please choose one of the following. All commercially available contrast agents are suitable for assessment of function, structure, and perfusion. We should use low MI imaging for structure, function, and perfusion. Frame rate should be more than 25 Hertz. And familiarity with use of contrast is a must for every echo lab. And point 5 is all of the above. Please go ahead and choose.
Okay, so while they brainstorm, choosing the correct answer, so Bharati, I'm going to stress echo. You stated in your lab you use contrast in most of the patients. Mm-hmm. Would you say you'd be using in over 90% of patients?
I certainly do, yes.
Yeah, and now we all know that people seem to think that the images are great, we don't need to use it, but we know that images can become great if they foreshorten the image. And by foreshortening, they are going to miss the apex. And with contrast, you bring out the apex, right?
Right.
So that is the main reason for us, even if the images are of good, so-called good quality, we still use contrast in stress echo because we don't want to miss a single segment.
That's right. It was indeed the point of the apex, and also the example that I showed about the infralateral wall, which is again a region which is easily missed.
Yes, absolutely. All right, so we have the answer now. So, well, I think Bharati, you've really taught the audience very well. I mean, 75% of them says all of the above, meaning that's the correct answer. Great presentation. Thank you very much.
Well, I'm happy the audience agree.
All right. So now we move on to the next presentation. Nicola, take the stage.
Thank you, Roxy. Hi, everybody. The title is The Incremental Value of Myocardial Perfusion During Stress Echo or Suspected Acute Coronary Syndromes. These are my disclosures. The starting point is that we all know that wall motion during stress echo, either you use echo or you use CMR or whatever you can invent to assess wall motion, is not enough. It's not sufficiently sensitive. And the last studies, the most recent studies demonstrated that we have approximately 50% of sensitivity if we use only wall motion and an unbiased cohort. So basically, we need perfusion to have a step up in sensitivity, and that's what other methods helped us to understand and inspect. CMR, CTA also recently, and PET demonstrated that perfusion can be assessed, but they share some limitations, if you will. Ionizing radiation, not for CMR, they cannot image in true real time, and DNA double strand breaks, whatever they can mean, have been demonstrated also for CMR. So this is what an image during echo is like for perfusion imaging. With very low imaging echo, you will hear both very low mechanical index or low mechanical index, indicating less than 0.2. 0.1 is excellent, and you can see the microbubbles actually flowing in the edematous region after ST elevation MI, obviously in the LAD territory, and also some pros, which is the real-time capability of echo, the subendocardial and transmural definition, high spatial and temporal resolution, and no ionizing radiation, obviously. There are also some cons, which should not be hidden. It's just the dependence on image quality. Obviously, if you have bad images in echo, you won't be able to assess perfusion. You will be probably helped by contrast to assess wall motion, but not for perfusion, and on subjective skills and experience. So we have these new guidelines.
So before you move on to the guidelines, Nicola, so what you've shown there is you compared your imaging technique with the other imaging techniques like PET, SPECT, etc.
Yes.
But would you say that we have got a contrast, we've got an agent which is a perfect flow tracer,
Absolutely.
compared to any other agent available for any other technique?
Yes, microbubbles are completely intravascular, and this is an advantage so that you can trace blood, actually. It's a percentage of the blood, so you can image blood, which is not possible with
So
the
it's a
other
pure
technologies.
blood tracer compared to any other imaging technique?
Absolutely. This is a clear advantage. This is the guideline recently written by greatest experts, and Roxy was one of them. Actually was leading. I think you're moving my slides, Berati, no problem. I would just kill you afterwards. This is the guidelines. Just a second, no problem. And the guidelines now state that I think we are going.
You got it now.
Huh? Sorry about that.
No problem at all. Okay, here are the recommendations for stress echo. That in stress echo laboratories, you need to have the availability of contrast echo, basically. So you, at least during stress echo, you need to consider in all patients the possibility to use MCE, which is something that helps for diagnostic, but also for stratification purposes, because you can go beyond wall motion assessment. And this is very important, actually. The recommendation is that obviously it should be performed, contrast echo should be performed when you're not seeing very well a couple of segments, contiguous segments, but if perfusion is your aim, you should use it also when you see perfectly all the 17 segments or 16 or 18 you want to use. But the key aspect here is that low MI, so low MI, or for US it's very low MI, less than 0.2 mechanical index setting, so the fundamental setting need to be used, because you're assessing at the same time wall motion and perfusion, and this is an advantage.
And with SonarView, actually the low MI we are talking about is in the region of 0.1?
Yes.
0.08, 0.1, 0.
Yes, 0.1 plus or minus 0.02.
Yes.
Yeah. So vasodilator, dobutamine, and exercise stress echo studies are there to be read. There are more than almost 4,000 patients for vasodilators, and it's dipyridamole, adenosine, or regadenoson lately. And also dobutamine, atropine, and exercise studies have been made, all demonstrating that sensitivity is very good, approximately 80%, a sensitivity which cannot be reached not using contrast and perfusion, but specificity may be similar or slightly lower, because that's the balance. How does it work? Well, it works just assessing how the microbubbles refill, it's called replenishment, the myocardium, after they have been flashed, meaning that you just automatically put your mechanical index back to the standard mechanical index, which is approximately 1.1. This have the microbubbles explode in the myocardium, where the concentration is very low, and you can see now flash, and then in the image which is triggered, now you will see the black myocardium, and then becoming more and more opacified by microbubbles. So this is a normal real-time image using very low MI on the left. Then you can see in the middle a normal triggered image. We use sometimes triggered images because you can better see the thickness of the myocardium in end systole, and you can sometimes stabilize the image. You can see it better if you're a novice in particular. And on the right, you can probably see that there is an abnormal triggered image at stress, where you can see that the circumflex lateral, most lateral, anterolateral, basal, and mid, in particular subendocardial aspect of the myocardium, is not replenished after those 1.5 or 2 seconds that are usually needed to assess perfusion. If you have normal perfusion, normal replenishment after 1.5 or 2 seconds at stress, you will have normal perfusion, so no coronary artery stenosis subtending if the epicardium is the culprit. But
and also, Nicola, what we are showing here is very relevant, because what you're showing here is very nice demonstration of wall thickening.
Sure.
If you go back to that, yes. So if you play that,
let's play it.
Yeah, you can see a very nice demonstration of wall thickening.
Yes.
And all you are doing is to just do a flash replenishment for perfusion.
That's it.
So
yes.
the setting is the same as you do in stress echo for wall thickening.
Absolutely.
And so you're not doing anything extra to look at perfusion.
No, there is in fact no reason.
So it's a bonus.
Yes,
that you can just
it's a bonus. It's a free bonus while you're using contrast. You can use contrast with exercise, stress echo, or dobutamine, or pharmacological dobutamine, either dobutamine or vasodilator, and there is absolutely no difference with the protocols you're using. You can use, for example, some of you in bolus. If you want, you can use it in continuous infusion if you want to be more accurate, particularly in your first cases of perfusion imaging. This is, for example, the type of protocol we use. And the type of protocol we use is a normal accelerated high-dose dipyridamole as a standard protocol, which gives you time to assess at rest and stress both wall motion, perfusion, just with a few small boluses of contrast, and also, if you like, the Doppler signal, so in this case color, but you can now use the pulse wave spectral Doppler to assess the velocities on the LAD. Obviously, perfusion gives it on a 3-vessel basis and not only on the LAD. This is the first case I want to show you. So you will need 2 answers, so have a deep look at both the images. On the left, you see at stress, wall motion using contrast. So the setting is the same. The only difference is that on the right, you can see a triggered imaging. So you just push a button on your machine, and you push a second button, which is flash. So flashing your heart will destroy the microbubbles where they have the lowest concentration in the myocardium, and it will allow you to assess the replenishment phase after the flash. If it's, I'm repeating this, if it's fully replenished after 2 seconds, it's normal, so there are no coronary stenosis. If it's not, it is not normal.
So how do you assess seconds? You're looking at beats, but how can you talk about seconds here?
Yes, in this case, you can see this is a typical dipyridamole echo, which gives you 100, 110 beats per minute. So you will probably need to check 3 beats. Okay, 3 beats after the flash. I'm trying to show you this, but the mouse doesn't work. Anyway, no problem. Do you think you can, Barati? Oh, great.
Yeah.
I will switch.
Let me be your assistant.
Okay, no problem. So can you see this? The flash, and then after 2 to 3 seconds, you will see that it is the right time to assess perfusion. We won't tell you what it is.
Yeah.
So in this case, I'm repeating the images, and the possible answers are positive for reversible wall motion abnormalities only, so you're looking at the left image where you see wall motion. Positive for reversible perfusion abnormalities only, so you look at the right image with the triggered imaging and the flash. Positive for both or negative. Please vote.
I think we need to highlight this, Nicola, that,
Yes.
you know, we said it before, but I think we need to say it at this stage also, that with the setting that we have for stress echo, right, we get wall thickening data very clearly. So perfusion, we are not doing anything extra, but just pressing a button for flashing and looking at replenishment.
Absolutely, absolutely. So, as you said, it's a very good way of saying this. It's a bonus.
So do you do it in all your patients with stress echo?
Definitely, definitely.
Yeah.
Yes, absolutely.
Okay, so it's well, they're still contemplating, so that's fine. So what about Bharati? Do you look at perfusion with your stress echo?
I look at perfusion in special study settings, not in the regular clinical setting.
Sure.
It's not often, let's put it that way. It's not completely...
So in high-risk patients, perhaps?
Yeah.
Yes.
For example, diabetics.
Yes.
But I've done that a lot in study settings where I would use then more the vasodilator stress rather than the setting of division.
Yes. And you said, Roxy, that you use it very much in the exercise setting also.
Okay, so I use it in dovitamin stress echo definitely, vasodilator no question, and in exercise echo also, if the patient hadn't achieved target heart rate, or if I suspect that this is a high-risk patients like what you said, diabetes, I will look at perfusion on exercise. So actually, 90% of my studies is wall motion and perfusion because it's easy to look at perfusion. So even if you don't get a good perfusion data, which you should get in 90% of patients, you've got the wall motion data to back up.
So maybe a practical question. So you said if the patient doesn't achieve a target heart rate, so you place the IV line beforehand?
Of course, because these patients are getting contrast anyway.
Yeah, okay.
They're getting contrast.
So that is probably one of the barriers for a lot of people for exercise.
Yes.
Echo. So
no, but with exercise we are giving contrast.
Yeah.
Right?
Okay.
And you have to give contrast in exercise because you lose the image otherwise. So 100% you need to give contrast. So all you are doing is now looking at perfusion on top.
Yeah.
It doesn't take much time. Okay, I think, all right, so there we are. So 2% voted positive for reversible wall motion abnormalities only, okay. 36% said positive for reversible perfusion, and 51 said positive for both perfusion and wall motion. In fact, 88% said there's a perfusion defect, which is, I think, is excellent.
Great.
Yes, this is excellent.
And I tend to agree actually with some of those who said there's wall motion abnormality, because if you look at it,
you're right. Yes.
Okay.
The standard answer was that there was only a perfusion defect, but as Roxy can say, and Bharati also.
The mid-wall is lagging behind.
Yes. The key point here is that contrast gives you such a high quality of assessing thickening and wall motion that it's actually rare that you find only really isolated perfusion defects, because when you go back and look at wall motion, you can finally find some type of wall motion defect in the region of the perfusion defect. But just to say that this was a typical perfusion defect in the apical.
Isn't it?
Yes, it's extensive in the apex and then down the anterolateral wall. So this is more than one territory.
And that's exactly the reason why I use perfusion, because it uncovers this subtle wall motion abnormality also. So especially in patients where you're not sure about the wall motion abnormality, perfusion brings it out.
In fact,
or if it is completely normal, then you ignore it.
It's so difficult to differentiate perfusion and wall motion, but contrast echo should be the name here.
That's right.
And here you can find this three chamber also in the inferolateral wall, the perfusion defect, so that it was not impossible to think that it was in both the territories that you could find coronary lesions.
So the additional advantage of looking at perfusion over wall motion is you see more extensive perfusion defect compared to wall motion. You can make a diagnosis of coronary disease, but if you want to make a correct diagnosis of the coronary disease, then perfusion gives you the true extent. The true extent. As you can see in this example.
We know is relevant, the extent, right? So this is just some data from one of our works, and just to show you that with the diameter of the bubbles, how many patients fall in different categories. So these were probably 1,200 patients or slightly more, and most of them had a very low incidence of heart events, as they are called, so a myocardial infarction and all-cause death, while a smaller bubble, but still relevant, had only myocardial perfusion defects with normal wall motion at stress, and higher incidence of events, while the smallest of the bubbles were the ones with both wall motion and perfusion, obviously, defects. So even smaller than this with the highest incidence of events. And passing to the suspected acute coronary syndrome setting, this is interesting. Here the guidelines have been rather conservative because if you read the guidelines, you should use this only when at least two contiguous segments are not very well visualized. But in this case, the first case I'm showing you, this is not very different from the Baratti's case. You can see that just underneath the papillary muscle, you can see the lateral, inferolateral endocardium, which is not thickening actually. The myocardium is not thickening. You can see this with contrast. It's very difficult to see images like this without contrast. And if you see the fourth chamber, I'm sorry, I have only the one with color with 2D standard imaging. But if you focus on the mid-lateral, anterolateral in this case, since we are in fourth chamber, you will quite easily see that with 2D imaging, there was nothing probably. While using contrast, I'm sorry, this is a little bit slow, you can see this defect here in the wall motion quite clearly still, because you can see can follow the endocardium here. So this is rest, and it is not stress. We can see that the angiogram obviously was consequent. This is even a milder defect that I want to show you. So we as echocardiographers know that the visual dependence of wall motion is very high. Sometimes perfusion defects can help you, as we said before, help you focus on few segments, maybe 1, 2 segments. Here it's not very clearly apparent probably, but it's much more easy here when you stand the concept that Roxy was explaining before of not being able to align perfectly with the apex. In this case, is really true. Contrast gives you the freedom to move and try to find the best spot. So in this two chamber, you see nothing wrong. But if you use contrast, you probably move a bit, and you can see that all the apex actually here is hypokinetic. So you are able to diagnose something wrong here and send this patient otherwise sent to home probably.
So that was a great example where if you had not done, if you have just looked at the wall thickening based on non-contrast, and you would say it's a perfectly good image.
This is, and I think this happens quite a lot.
Quite a lot. So you have foreshortening, and that's why you're seeing it that way. You must use contrast to see the apex well. Yeah.
So let's see the second and last case. I think yes. Yeah. This is a patient with prior MI in the right coronary territory, so the inferior segments, treated with PCI, male, hypertensive, hypercholesturemic, no diabetes, no family history of CAD, of coronary artery disease, and obese. So on the left, non-contrasted images, and on the right, the contrast still at rest, just to stress this. So not perfect images, but maybe they show basically an akinesia here, which is due to the prior MI on the right coronary artery disease, and was known, but nothing else. And again, an example from Roxy's explanation. Here we also we have better images, but we also tend to align better with true apex, and we see something that was not feasible to see here when we foreshortened the two chambers. So this is real life. When you cannot hypothesize, you can always get images perfectly aligned. Oh.
Okay, was that an MCQ?
Basically.
Yeah.
This was an MCQ. That was supposed to be an MCQ.
Yeah.
What do you think of this? Normal apart from prior MI on the RCA, now abnormal also in the LAD territory, now abnormal also in the circumflex artery, territory, and now abnormal also in the LAD plus circumflex territories. You vote, please.
Okay, so while they continue to vote, So Nicola, do you use regodenozone at all as a vasodilator?
Well, actually, I'm not using it. Maybe because of the cost, maybe, but it's a very efficient vasodilator and well tolerated. Well, we tried it, but we don't use it routinely. Yes, I think the problem lies on doses when you use different vasodilators.
Yes.
It's the same for adenosine.
Yes.
If you push the vasodilator enough
Yes.
to obtain the possibility to see ischemia
Yes.
with wall motion, you
Yeah.
can do whatever. You can
Dose
use
you like.
whatever, yes.
Yeah, yeah.
Otherwise, I mean, you were a proponent at the times when you were studying perfusion, for
Yes.
example, of a lower dose of
Yes.
dipyridamole, right?
Yes.
And that was perfect for perfusion,
Yes.
but maybe not perfect for wall motion.
That's right. I think the regodenozone has the advantage that it's a single bolus dose, 400 microgram, given very quickly over 5 seconds. And you've got 3 minutes to image, 3 to 4 minutes. So you've got plenty of time to image. The whole study finishes in 10 minutes, but it is prohibited by its cost. It's a costly agent, but the nuclear cardiology department uses it a lot.
Okay.
You can steal it by the...
Yes,
you can steal
yes,
from them.
Yes, absolutely. No, that's what we have regodenozone protocol in our department.
Nicola, I have a little question. So you showed 2 examples now with apical wall motion abnormalities, one of which, the first case, was actually pretty good image quality, and the second was not such good image quality. So when you have good image quality, would you still recommend giving contrast then? I think in the second case it was very obvious.
Well, yes, it really depends on the clinical situation you're going to
Because most
meet.
people probably wouldn't.
Yes,
I
yes,
guess.
yes. But if something is wrong with your clinical judgment and the patient has some type of symptom which is not very clear,
then
I
you
would
should use
recommend
it,
to use it because you can uncover
Right.
something that you couldn't see, even with perfect images.
If you're suspecting coronary artery disease in that patient, then you must see the whole of the heart in a perfect way. You cannot foreshorten the apex because that's where the abnormalities mostly occur.
Yeah, and this is where the recommendation is where clinical management is going to be dependent. Class 1A recommendation
for giving contrast.
I think we can't stress that enough.
Yes, yes, and if you've seen the cases, that is really important to do that.
I agree.
Okay, so very quickly we are moving. So we've got the answers now. In fact, 83% said there is additional ischemia in the LAD and circumflex together.
Really?
No, but half said it's only in the LAD, the other half says it's in both territories. But in any case, I think 80% picked up additional wall motion abnormality in the right territory, that is LAD.
I think they may have been tricked for the circumflex by the one of the problems.
Yes.
One of the problems of contrast. I mean, we shouldn't. We should say that contrast is not perfect when you need a lot of experience for perfusion in particular. Probably they interpreted the typical artifact in the circumflex territory as something positive at some point here, but this needs caution. You can see when it passes through that there are moments, there are frames where you can see perfect perfusion there. It's just when the people breathe that you can have those type of artifacts. And that's the reason why you need a little bit more of training when you interpret perfusion than for wall motion.
There's no question. For every technique you need training, whether it be MRI, SPECT, echo. You can't do things without training. And there is training guidelines, and one must follow that.
Sure. And this was the angiogram?
Yeah.
Yeah, and we are finished, thank you.
Yeah.
So LAD.
Excellent. Well done. I think you've also more or less convinced the audience, and also the way they answered the question, they answered it perfectly. Right? 82% said perfusion abnormality in the right territory. So I think we are now, we've got some few questions. We've got a few minutes for that. So let's look at some questions from the audience. I think, okay. Well, I think it's a good question. What are the contraindications for the use of contrast echo? In what setting we cannot use contrast echo? So what are the contraindications?
I think the only real contraindication is allergic reactions, possible allergic reactions to the components of the bubbles. In earlier times, one of the contraindications was also a large right to left shunt, but this contraindication has been removed. So I think the only real contraindication is hypersensitivity.
Yeah.
Allergic
Okay, so that answers the question. So the only contraindication is previous hypersensitivity to that particular
I
agent.
think, Roxy, they want you to clarify a little bit about using the acute setting or post-acute setting. The fact that you have chest pain or not chest pain. And I think that the use of contrast is most useful when you need to clarify a clinical situation,
Yes.
not when you have an asymptomatic patient, right?
No, no, absolutely, absolutely. So let's move on to another question, which is again clinically important. If you want to differentiate LV thrombus from the tumor, you need to use contrast for perfusion. So the question is, MI 0.1 and less?
Yes.
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 So that's right. So MI as low as 0.1, if you're using SonoView, that is the right setting to look at perfusion and function.
You need to be a little bit aware that if you use a higher MI, you can enhance the fibrotic components of tissue. And this is very important and also may be useful in some applications, right?
Yes, yes. I think you have a good paper in that.
And use flash replenishment.
Yes, of course. Flash replenishment is a must to look at perfusion more accurately.
Yeah.
Yeah. So we have got another question, which could be. Okay, very quickly. What is the best? Okay, how long after MI, myocardial infarction, is stress echo safe to minimize risk of cardiac? Okay, this is a general question, but contrast also comes into some extent. So, how long after acute myocardial infarction can you actually do a stress echo?
Well, it is actually very safe. So there is no real reason why you wouldn't do it in.
Yeah.
But why would you do it?
Okay, so the question is, why would you do a stress echo? Yes. So, yeah. Yeah, that's right. So the patients have an infarction, and the wall motion is completely normal.
Okay.
Right, and the patient doesn't have chest pain, mild troponin rise. Are you going to CAT this patient? The patient is fine. Are you going to do a stress echo to actually find out whether there's an extensive ischemia? So risk stratifying the patient, I would do it, 48 hours after the patient has is stable. Stable.
Yes, stable.
And we are talking about in absence of wall motion abnormality, not in presence of large wall motion abnormality, which can cause cardiac rupture. Okay, I think we are coming now. We are now approaching the end of the webinar. I would like to close this webinar by highlighting the key take-home messages from this webinar. Contrast echo improves assessment of regional and global function through improved image quality and better reproducibility in our daily clinical practice. Contrast echo helps to improve diagnosis of cardiac structural abnormalities. It gives interpreters confidence to assess cardiac structure and function. For optimum assessment, almost all patients undergoing stress echo will require contrast administration. It is a state-of-the-art echo actually to use contrast. It is cost effective. Perfusion information is very feasible during stress echo, as has been shown. It provides both incremental diagnostic and prognostic information beyond wall motion. Both wall motion and perfusion help guide which patient may benefit from coronary intervention. Finally, low MI contrast-specific imaging techniques should be used for optimum assessment of cardiac structure, wall motion, and perfusion, except when you are suspecting non-compaction, where you require a bit of harmonics from the fibers. We will now close the webinar. Thank you, Bharati and Nicola, for your great contribution.
Thank you.
Thanks to Bracco, who supported this webinar with an unrestricted educational grant. We hope you enjoyed this time with us. You'll be able to view again this webinar offline in a few days on the EACVI website. Thank you.